Welcome back to our discussion on the shoulder and shoulder injuries in women. I'm here with Dr. Q and Dr. Woolridge. Let's continue our discussion on shoulder instability, and now we'll discuss treatment and recovery options. Dr. Q, how do you treat shoulder instability?
So that's actually a pretty hotly debated topic right now in orthopedics. The historical thinking was after one dislocation, do some physical therapy, like we had been discussing, and you get back to your activity. We're now seeing that younger patients, male patients who play a contact sport, have a significantly higher risk of recurrence or having another dislocation. We know that every dislocation event can damage the cartilage, the bone, the labrum, and so we're becoming a little bit more aggressive based on recent research that patients who are below the age of around 20 to 25, male patients particularly, have been shown to have a higher rate of instability who play contact sports. So everything from basketball, soccer, football, anything where you're going to be hit by somebody and have the risk of recurrent dislocation, the surgeon might counsel the patient to have a surgery. Then that comes into the when do you do the surgery? During the season? Do you do it after the season? So that's a very nuanced discussion between the patient, the family, and the surgeon to discuss the appropriate timing. But we do know that we are now recommending surgery to stabilize the shoulder after the first time in patients who are in that population. Other patients who may be a little bit older, they do it like playing sports, but they had an acute trauma where the shoulder dislocated. Those patients can be treated with physical therapy, and the recurrence rate is not unacceptably high in that population. But if somebody has a second dislocation, that's when we start talking more about surgery. Um, because, like I was talking about, the more dislocations you have, the more you can damage the shoulder. We had previously discussed the anatomy of the shoulder. So it's a golf tee and a ball surrounded by structures that help stabilize the shoulder. The labrum gets damaged when you dislocate. You have your socket, you have your ball. The ball comes out and it drags the labrum, and it tears the labrum, and the ball also hits the front of the socket, and so you get a little indentation on the back of the humeral head called a Hill-Sachs lesion. So you can imagine the more times you dislocate, you're wearing away the bone in the front, kind of like the ocean. The more times the ocean draws the sand back, the bone starts to fade away, and then the deeper the hole in the back of the humeral head goes. And so you can imagine this is a road, this is in the car, and you're driving, and all of a sudden there's less road here and less road here, and so easier for the shoulder to dislocate. And so we're starting to operate a little bit earlier in these patients to prevent these complications because, again, more research has shown that the degree of bone that's lost on the socket, once we hit a certain threshold, just fixing the labrum to recreate that bumper is not enough. And so we have to add something called a remplissage, where we fill the hole in the back of the humeral head, and that's been shown to help up to a certain amount of bone loss on the socket. But after around, it was 13.5% of bone, this is 100, 13.5 off the front, we show that even if we do a soft tissue procedure or fixing the labrum with a small camera instead of a big open surgery, the risk of recurrent instability or failure of that surgery is unacceptably high. So then we start discussing more complicated surgeries where we actually take a piece of bone to recreate the socket of the shoulder to help recreate that bone and then fix labrum on top. And so that gets a little bit into the weeds of all the complicated options to treat shoulder instability, but it really falls into two buckets in surgery. The first one is we go with a small camera, we fix the labrum, which is the bumper of the shoulder, with or without filling the hole in the back of the humeral head, which studies now show is very helpful in preventing recurrence. So we're doing a little bit more frequently.
Just to make sure people know the humeral head is the arm
Is the
bone.
ball,
Yeah.
yes, the ball of the shoulder,
Yeah.
versus recreating the bone of the socket. So there's two different buckets of it. A soft tissue procedure, we call it, or a bony procedure. There's the two different options, and it can get a little complex. So discussing with your surgeon really what your imaging shows and really what your goals are, and a lot of nuances go into a surgical discussion about shoulder instabilities, which is why we're trying to get it sooner rather than later to prevent having to do these more complex open bony procedures, which do have inherently a higher complication rate. And so we always do discuss this with patients about what their imaging shows, what their goals are, and really what the best surgical option is for them to obviously decrease their risk of complications to give them the best outcome to get them back to their life.
Yeah, I wanted to add to that. First and foremost, I love a good metaphor. All of those were top notch. Also, I want to say this is a really important education point for many of our primary care providers, many of our emergency medicine doctors, urgent care doctors, because a lot of times when somebody has a shoulder dislocation, they're going to the emergency room or they're going to, just their primary doctor to, oh, okay, we got to pop back in. All right, just wear a sling for a bit and then go back to your sport. And so it is not common knowledge in the medical community, I will say, coming from a pediatric background, a primary care background, to have a surgical conversation after a first time shoulder dislocation, particularly for young athletes, for our teenage athletes. So that is really, I think, an important, new data that is coming out that people need to be more aware of. And I'm glad that the public, hopefully, with these types of conversations, or increase awareness that, hey, if your teenage athlete has a dislocation, that's not really something to brush off and to kind of get back to your sport and just hope for the best. It's something to really consider having these conversations. I also have many patients who will come to me. I have some that will come after a traumatic dislocation, and I'm quick to send them over to my surgical colleagues. But I will also get, again, the 30, 40, 50-year-old patient who says, I've just got this chronic shoulder pain. It just kind of hurts. It doesn't feel good. It feels, different than the other shoulder. And I ask them about their history of any injuries to the shoulder. And they're like, oh, yeah, I've dislocated it like 10 times. It's fine, whatever. I know how to pop it back in at this point. And I put my medical poker face on, but internally I'm panicking and I'm concerned about what the interior of their shoulder looks like. So again, in those patients, I wish that they had somebody like Dr. Q who could intervene early on and help provide more options for management to prevent some of the bony damage that can occur with those recurrent dislocation and instability events.
And then after treatment, what is the incidence of recurrent instability?
So again, a lot of research has been coming out recently about this. I talked about the risks of recurrent dislocation. So we know that in some patients where the divot on the back of the humeral head or the ball of the shoulder, it depends a lot of research on how deep it is, where it's located on the humeral head. Now looking at the angle of it and kind of where it's going to engage on the socket as the ball is rotating is showing that we should do that remplissage or filling procedure to help stabilize the shoulder. So a lot of studies coming out now are suggesting to use the remplissage to decrease recurrence rates after soft tissue surgery. And I think really being able to identify which surgery is best for the patient based on their imaging is important. So we know that unrecognized bone loss, or both on the socket and the ball side, are big risk factors for failure of just fixing the labrum. And so I think surgeons have to be critical and really talk to their patients and say, listen, this is what the imaging shows. We need to do a bony procedure to help stabilize you and prevent a recurrence in the future. Like Dr. Woolridge was saying, the more dislocations you have, you not only damage the labrum and other soft tissue structures, but the cartilage. We want to prevent arthritis in all of our patients, but particularly those young patients. The more dislocations you have, the more you can injure the cartilage. And I also do shoulder replacements in my practice. And so I've seen a lot of patients who've had 10, 15 dislocations, or they've had an instability surgery where the cartilage damage happens when you're young. And if you keep dislocating, the cartilage damage continues to compound. And then they're in my office with arthritis and they need a shoulder replacement. And so our goal is to help our young athletes get back to sport safely and with the longevity of their shoulder for their whole life. And so we really have to be critical when we talk to patients about their injury, what their goals are, and if there are multiple dislocations or features on imaging that concern us, we should be honest with them and talk about what the potential options are to get them back to sport safely to give them a good shoulder for the rest of their life.
And are women at any greater risk of recurrent instability, or is that not and no difference?
Yeah. So, like Dr. Woolridge showed, people who can put their thumb on their forearm have something called ligamentous laxity, or kind of loose jointed. Their collagen, or the tissue that makes up really our whole body, skin, uh, tendons, everything, is loose in some patients. And so in my office, I'll do something called the Baton criteria. Well, I'll have you show me how loose you are, your elbows, your knees, your finger. And if you have a high Baton score, then that tells me you're ligamentously loose. And so some patients do have a higher risk of recurrent instability because their joints or their capsule or their tissues are just looser than everybody else's. And so in those patients, we know that going into a surgery. And so when we do the labral repair, we take a bigger bite. And so a lot of collagen is used to help stabilize that labrum. Or if it's We have some bone loss. We'll say, hey, your tissue's not something that we trust or that we can really count on forever. Maybe we do the bony procedure to give you extra heft in your shoulder and help prevent further dislocations. And so that's a very nuanced discussion again with the patient and really understanding who they are as a patient, what they're bringing to your office, so we can give them again the best treatment that's personalized to the patient instead of just treating an MRI. Really, it's talking to somebody, getting to know them is, I think, the most critical part of a patient visit.